The title is correct with challenges of MDR-TB because there are many sub-challenges within the bigger challenge of MDR-TB. And with referring to multi-drug resistant tuberculosis, I also include XDR and pre-XDR and other further forms of resistance with MDR. So the first challenge is actually the numbers. For a long time, we did not have a good idea of what the numbers of TB is in children. And the WHO published a few years ago about 500,000 cases. A year later, it was 1 million cases. But in a recent estimate done by Peter Dodd and James Seddon and the group, they estimated from the publications that are available in the literature as well as the information from the WHO that there are about 850,000 cases of TB every year amongst children, with 58,000 children with INH monoresistant tuberculosis, 25,000 cases of MDR-TB, and 1,200 cases of XDR-TB. But then we also have to remember that it's not only the children that have disease, but also those that are infected that are important because they may still develop tuberculosis, and the estimation is that there must be about 2 million cases of MDR-TB infections among children. So how much then, or how does MDR-TB compare in HIV-infected children compared to HIV-uninfected children? We've been doing surveys, 2-year period surveys in Cape Town in Tygerberg Hospital, and we could never show in any of the 2-year periods that MDR-TB was more common or drug-resistant tuberculosis was more common amongst HIV-infected patients compared to HIV-uninfected patients. But when I sat with a talk, I just looked at the whole cohort of 14 years that we've collected up till now from 2003. And if I break it down, we have 2,112 cases of confirmed tuberculosis, and we had both the HIV status as well as the drug susceptibility pattern in 1,738 cases. And if one looks at that cohort, we can actually see that there is a difference. And these are the numbers. We had about 20% HIV-infected patients, and it is definitely decreasing the HIV infection amongst the culture-confirmed cases. But there was no significance when one looks at the INH monoresistance. But when we look at the MDR-TB, there is a difference. And if we add all the rifampicin resistance, because the one aspect that we are often forgetting is that rifampicin monoresistance is actually increasing. Definitely in our situation, but certainly I think also in the rest of the country, as we have seen with a new report, the surveillance report that came out recently. And if one looks at all the rifampicin resistance in total, there is a definite increase, or it's more often in HIV-infected patients compared to HIV-uninfected patients. So the most difficult part possibly is to confirm tuberculosis in children, and if you cannot confirm it, it's also very difficult to actually say this child has drug-resistant tuberculosis. Firstly, we must just be careful not to include infection and disease, because children may be infected with tuberculosis, not being ill with a disease of tuberculosis, even if they have a positive gene expert, because the gene expert remains positive. It's not a follow-up test. It should only be done in the beginning. And even with culture-confirmed cases, they may only be infected, as a recent article from Marianne Loveday from KZN showed that some children have positive cultures, but the X-rays are normal, they're clinically, physically well, and do they have disease or do they have infection? So we just need to be careful with that. And in HIV infection, of course, we have to exclude other diseases that can look very similar to tuberculosis, and they can coexist in the same patient. So to diagnose drug-resistant tuberculosis, we actually need the organism, and for that we need to take these specimens even before we start treating. So in any case of tuberculosis in children, it's best to obtain specimens before you start treating, and it's possible in almost all cases. The only cases where I would start the treatment immediately are the suspected tuberculosis meningitis cases and maybe the miliary tuberculosis cases, but all the others can wait a day or two before they start treatment so one can get the specimens for drug susceptibility testing, well, culture and drug susceptibility testing, and also genotypical confirmation. And I think that, in my personal opinion, every child that has a positive culture should have a drug susceptibility test done, at least if they're HIV infected, but mainly every child with a positive culture should have a drug susceptibility test done. So how do you make the diagnosis? So I said it's a bacteriological diagnosis. You cannot make it on X-ray. You cannot clinically decide whether this child's got drug-resistant tuberculosis. The history may be important. So confirmed if you have an isolate of the child and you can confirm the drug susceptibility test on the child's specimen. But the probable cases are those that are in contact with an adult with MDR-TB or XDR-TB. And we know that the concordance between adults and children is between somewhere 78 to 90%. And it varies a bit because we have so much tuberculosis in South Africa. Patients may be exposed to more than one case, and the cases do not necessarily have the same drug susceptibility pattern. But once you have a source case and the child is in contact with that source case, and that is the only source case you know, you actually should treat the child as if the child has drug-resistant tuberculosis. Then we have a suspect group. Those are the children that we are treating with first-line drugs. We are sure about the diagnosis. We are sure about the adherence to treatment. And despite all of that, the child fails treatment. And in that case, we should also consider switching to MDR tuberculosis treatment. So what about a gene expert compared to culture? Culture is still the most sensitive way of obtaining a positive result from children. It's better than expert. As you can see, the detection threshold is lower with culture compared to expert. We need less organisms per milliliter of fluid. The speed, of course, is much faster with expert, and that is the advantage of it. The positive yield for cultures depends very much on the severity or the extent of disease. It's between 30 and 70% in children, but only 60 to 70% of those are expert positive with the current expert that we have. There is a new expert on its way, hopefully, called the expert ultra, which will be hopefully more sensitive and will have more or less the same detection rate as culture. The specimens, any type of specimen can be cultured, but also expert is more and more recognized to be able to identify tuberculosis in different specimens, not only respiratory specimens. So the treatment of drug resistance is, and I put it in brackets or in brackets, rapidly changing. It's nothing comparing with HIV disease. I mean, we have had 2 new drugs in 60 years, and a few repurposed drugs, I think 3. So, but the point is it is changing, and we have to start thinking about how can we put together a decent regimen to treat any type of tuberculosis, not only drug susceptible, but also drug resistant, and also XDR-TB. In children, we're still struggling with the doses of the second-line drugs that we've been using since 1940. And it's only recently that we've been doing pharmacokinetic studies to see what the correct dose for children are, because we've always just used the adult data to work out a dose for the children. This is changing, and I'll show you some of the data just rapidly. And recently, the WHO has also recommended a 9 to 12 months regimen, and I specifically say 9 to 12 because everyone is referring to either the Bangladesh regimen or the 9-month regimen. It's not the 9-month regimen, it's 9 to 12 months. And this is specifically for patients with RIF monoresistant and MDR-TB. strictly MDR. That means only resistance to INH and rifampicin, not to any of the other drugs in the regimen. And so in our context, it has limited application because we know that many of our MDR cases, 60% are resistant to PZA and 40 to 50% are resistant to ethambutol. So we do need to get more rapid drug susceptibility test results to actually know not only about the first-line drugs but also the second-line drugs to actually be able to use this regimen also in children. And there are many treatment shortening regimens currently being tested in adults. And if it works in adults, we don't need to retest them in children. The only thing that we then have to do is to see whether these regimens are safe and that we have the correct doses for each of the drugs in children. And these are just some of the current studies that is ongoing, and you can see the combinations, many of them with new drugs, PZA, bedaquiline, pertonomid, and there's moxifloxacin, which we rarely use currently in children, the younger children, because of the size of the tablet and the child-unfriendly drugs that we have. And then on this side, there are just a couple of studies that is, which I will refer to later, on preventive therapy, because we need to get prevention for MDR TB and even XDR TB, if at all possible, in the context of MDR cases. So the WHO 2016 HIV guidelines says ART is recommended for all patients with HIV and drug-resistant tuberculosis requiring second-line anti-tuberculosis drugs, irrespective of CD4 count and within the first 8 weeks of treatment. And that is correct. We put them on treatment as quickly as possible. We would usually start within the first 2 weeks. But there is one exception, and that is with tuberculosis meningitis, where we are a little bit more careful to start the ARTs too early because of immune constitution inflammatory syndrome, which can be fatal if there's increased raised intracranial pressure due to enlarging tuberculomas or pseudoabscesses. So in those cases, we need to be careful and we need to be very alert, not to think that the vomiting is due to the drugs, but the vomiting can be due to raised intracranial pressure. And the children can't always say that they've got headache. So this is something that we do need to be aware of. Drug-drug interactions, fortunately at this point, seems to be much less with the second-line drugs, but we need pharmacovigilance. We need to know more. We know too little about the different drugs and the drug interactions with the second-line drugs, especially also now the new drugs that we are using, and which is certainly going to be used in kids soon. And I've mentioned there the laminate. It seems like the laminate is safe with all the currently used ARVs. Bedaquiline, there is an influence of lopinavir, which increases the dose of or the concentration of bedaquiline and also of its metabolite M2. And on the other hand, efavirenz can reduce it by 50%. And the question is, does it really matter? I think the answer still needs to be obtained, and we don't really know whether we have to make adjustments for that in the children. And the new ARV seems also to be fine with the second-line drugs at the current moment. So these are just the new, and I mentioned, I call it here the WHO MDR TV drug groups, because it's not really second-line drugs anymore, because it's also ethambutol and PZA and INH is included here. But the groups has changed. First it was group 1 to 5, now it's group A, B, C, and then there's a group D1, D2, D3, and I'll just quickly mention them. And I've added the recommended doses, and these doses, some of them come from very recent pharmacokinetic studies in children. For instance, the levofloxacin initial dose, and if I remember correctly, it's still in the WHO guidelines, the 7.5 to 10 milligrams per kilogram per day. And we certainly found that 15 to 20 milligrams is at least what we should give, and possibly even more than that, but for that we need more proof. Moxifloxacin dose, we do not know the dose for the younger kids yet. Even the older kids, older than 7 years, it seems that 10 milligrams per kilogram is really the lowest you should go, not lower than that. Maybe we should, we are doing more PK studies to increase that dose. With the second line injectables, it should be, that's a mistake, it should be 18 to 20 milligrams per kilogram. Because it's important that you give enough, but you also must not give too much because it will increase the hearing loss. And of course, we are trying to steer away from the injectable agents, and hopefully we will have a regimen that we can test without the injectables. And then ethionamide, cycloserine remains the same. Linezolid, 10 milligrams a kilogram twice a day is the current dose, and we're looking at that as well. That's for children younger than 10 years, and over 10 years, 300 to 600 milligrams a day. We usually do not give more than 600. And clofazimine is a problem because it comes currently in South Africa. It's only available in a 100 milligram capsule, which is a problem to give for the younger children that actually need clofazimine as part of their regimen, especially in pre-XDR, XDR TB. And we have to dose them every second or third, even fourth day. Unfortunately, it has a long half-life, so you can use it in that way. But what we really need is a 50 milligram and even a smaller gel capsule, which is available, but we should just get them in the country. Just mentioning bedaquiline. Bedaquiline is currently not used for children less than 33 kilogram or less than 12 years of age. It's actually not approved in this country yet for children under or people under 18 years of age, but I know it's being used. Delaminid is available on compassionate basis from the age of 6 years and a weight of 20 kilograms, which is fortunate because that at least gives us the opportunity to treat children with XDR 6 years and up with the new drugs. And in some cases, we will make exceptions to use it even in the younger kids because it seems like quite a safe drug. So the other challenge is how to administer these drugs, and you can see the two pictures there, the injectables that we have to give, the handfuls of tablets that these children have to take. This is a child, this boy here, has HIV. He actually caused his own MDR TB by selecting his drugs. When he had drug susceptible TB confirmed, and within a few months he was MDR because he was not observed taking his therapy. Mother just left the tablets on the table, and he's sort of pick and choose. But that's what he landed up with every morning, that he had to take those, and then also in the evening some more, and then the injectables is not included there. So child-friendly drugs, child-friendly formulations is a huge problem. We're busy addressing that. And for levofloxacin, for instance, when we do the trial, we have a dispersible 100 milligram tablet which tastes like mint, which will hopefully also get to the market for treating other children. So toxicities is another problem, adverse effects of the drugs, and we know that there are combined toxicities, for instance, with mitochondrial toxicity, with linezolid and bedaquiline, and some of the NRTIs and NNRTIs. Adverse effects is probably less in children than compared to adults, but there are no really good prospective trials to see how much adverse effects there are in children, and that one really needs to look at as well. And we need to develop an injectable sparing regimen, because that's probably the most serious adverse effect that we have with MDR TB treatment, is that about 25% of the children develop hearing loss of some form. They're not deaf, but many of them have hearing loss, especially at the higher frequencies. I had to do a talk on specifically adverse effects in Australia last year, and I sat down and just started thinking about all the adverse effects, and I could alphabetically arrange them from A to V. And if you can help me with W, X, Y, Z, then it will be fine. And I had to make some adjustments, like hepatitis will be under jaundice to put in the J, but there are a lot of adverse effects with second-line and even first-line drugs. And as you can see, I've added for your convenience the drugs that can cause them, because I was actually going to have a quiz to see which one causes which. Central nervous system problems, we have hallucinations, insomnia, sleeplessness, weakness with the fluoroquinolones in children. I'm not going to go through them all, it's just too many for now. Hearing loss, as I said, hair loss, I've recently realized that children actually lose quite a lot of hair due to certain drugs, and it's actually INH and ethionamide that does it. And even working with TB for now almost more than 30 years, I don't recognize all the adverse effects. So it's something that one needs to take cognizance of. Idiopathic intracranial pressure, raised intracranial pressure is something that we have recently discovered, I would say by chance, because we had to investigate children with who started on a developmental study, and we also had to do a fundoscopy, and 2 of the children actually turned up to have papilledema. And the reason for that was the fluoroquinolones, which we did not realize. So it's an under-recognized problem, and something that we have to also look into more specifically to see how common is it really. So we're still learning about the adverse effects. And this is just the last slide. And actually, tendonitis is a very rare problem in children. We've not seen this in children, but just to be aware of this. The outcomes in children is actually quite good when we treat them. Even with XDR TB, we have very good outcomes. Up till now, at our institution, we have not lost a single child to XDR, which we diagnosed before they died, because that is the other problem, getting the results in time. And it seems like the outcome in this one study, published in 2012, there was no difference in HIV-infected compared to HIV-uninfected children, but in our own experience, HIV-infected children have a higher mortality. The last point I just want to make is about prevention, because I think it's a very neglected area. Even the WHO does not recommend prevention or preventive treatment for MDR or XDR TB. And I'll mention just what a group decided last year. But it's not only preventive treatment, it's also infection control in institutions, at home, to protect the children against development of tuberculosis, being infected in the first place, but also development of tuberculosis. And to effectively bend the curve, as to say, to decrease tuberculosis sufficiently, it was said by Dye et al. That one needs to address infection. And this is what I mean, that you have to treat, but you also have to have other measures to actually get it down to very low TB rates by 2035. So if we don't do that, if we don't treat infection, we're not going to win. And that's not only for drug-susceptible TB, it's also for MDR TB. So that is what we need to address. And also in the pillars, it says preventive therapy for NTB strategy. I said that the WHO doesn't support it. There are no randomized controlled trials, but we know of about 10 trials, published and unpublished, that actually says that it does work to give prophylaxis. And we have seen that in the Western Cape in our own experience as well. This is a policy brief that was written last year, beginning of last year, with a meeting of about 50 experts from 19 different countries, deciding that we should really advocate for preventive therapy in MDR TB children, children in contact with MDR TB cases. And also for high-risk patients such as HIV-infected patients, they should also be on prophylaxis. And we know that the fluoroquinolones are almost as good a drug as INH for prevention. The only thing is that no one ever tested it yet, and that is why we have currently 2 registered randomized controlled trials comparing fluoroquinolones or levofloxacin specifically compared to placebo, and the third one that will hopefully also start next year or maybe the year after, depending on when we have all the data, comparing the laminate to INH as prophylaxis. So there is the possibility of protecting patients against MDR TB. The problem at the moment is what to do with XDR cases. Hopefully a drug like the laminate or one of the new drugs can solve that problem. But for the moment we have no specific answer to that problem. So we have many challenges. And it's for us to find a solution and solutions. And we also have young aspiring doctors that will help us hopefully in the future to solve some of these problems. Thank you very much.